Many thanks for this introduction, and I would like to say that that's really an honor to be here, and many thanks for the organizers, and particularly many thanks to Simona for this kind invitation. So I'm going to give a talk on gout with some news in 2023. So, in a sense, gout is a disease which is very easy to cure, and you can cure definitively all of your patients if you are capable to decrease the urate level below the threshold of solubility, which is considered to be close to 6 or 7 milligrams per deciliter. Why? Because when the urate levels exceeds its saturation point, the urate, which is soluble, become crystals, and the crystals is clearly the culprit. And we have learned from Leo's talk that the crystals can lead to the activation of a protein complex, which is an NLRP3 inflammasome, leading to the high production of IL-1 by macrophages within the joints of the patients. So it will lead to acute flares that are acute arthritis, which are localized, of course, where the crystals are, so meaning in the lower limbs. So one of the first questions we should have when talking about gout is why in human urate levels are so close to the threshold of solubility. When you look at the urate level in birds, in cats, or in dogs, the urate levels are very low, close to 1 or 2 milligrams per deciliter. But it's totally different in human because the urate levels are always close in the general population, close to 4 or 5 milligrams per deciliter. And there are two explanations for that. The first one is that during the evolution of the human species, we have lost the uricase, the activity of the uricase, which is the enzyme which degrades uric acid to the more soluble component allantoin. This is the first point. The second one is that in parallel, there have been some modification in the gene encoding for GLUT9, which is one of the major transporters of urate, which is capable to reabsorb the uric acid within the kidneys. And at the end, in the human, we have a raise in the urate level. The second point is when you are facing a gout patient, why in gout patients the urate levels exceeds the solubility? And what we have learned from the last decade is that contrary to what we have learned with Leo and Korn doing our studies, diet is not very important, but the genetic clearly is a clear explanation for the increase in urate level in patients with gout. We know that from different GWAS, and in the last GWAS conducted by colleagues from US and New Zealand, Tony Merriman, we have learned that there are more than 300 loci associated with the disease. And in the majority of cases, these variants, the SNPs, are present in genes encoding for urate transporters, mainly localized within the kidneys. So it's very important to have in mind that gout clearly has a strong genetic component predisposition. Apart from the genetic, do we have some risk factor, causal factors associated with the disease? Yes, we have, and they are indicated in this slide. One of the most important is CKD. In CKD patients, they are exposed really to an increased risk of developing the disease. It is causally associated. Same with obesity. And we have a lot of Mendelian randomization studies which have clearly demonstrated that obesity is causally associated with an increased risk of having high level of urate and an increased risk of developing the disease. Insulin resistance by another mechanisms, hypertriglyceridemia with another mechanisms, of course, and you all know that diuretics are also as well a cause of increasing the urate level. So the mechanisms for all these factors is indicated here with this genetic predisposition, with the risk factors, CKD, obesity, insulin resistance. There is a decrease in the fractional clearance of urate by the kidneys, meaning that in the general population, roughly 10% of the urate, which is filtrated by the kidneys, is eliminated in the urine. Totally different in gout patient. And in gout patient, you can see that there is only 5 to 6 or less % of the urate level filtrated by the kidney, which are eliminated in the urine, meaning that it will lead ultimately to an increase in the urate levels. So you have in this slide a nice illustration on the link between CKD and incident gout. If you look in this study, the risk of developing the disease according to the clearance of the creatinine, you can see that there is a dramatic increase in the risk of developing the disease when the clearance is below 60 milligram per deciliter. This is what we see in daily practice. And a typical gout patient very often is suffering from CKD. So one of the questions we might have is, what is the most important? Is it diet? We have all learned that diet was very important in the genesis of the disease. Or is it the genetics, the heritability? So to answer these questions, colleagues from US and New Zealand have just investigated the weights of diet or the weight of heritability, the genetic, on the percentage of variance of urate level. So they have done that using different cohorts of patients for whom they had questionnaires to identify diet and DNA to compute a genetic score. And what they found, and it was very surprising at the time, they found that heritability explained more than 20% of the variance of urate level, whereas diet explained very few, less than 1% of the variance in urate level, meaning that overall in gout patients, the genetic really plays a key role as compared to diet. So we are in a situation where, as was explained by Leo, patients are going to have very high level of urate, and then they will develop the disease. Is it always the case? No, it takes years and years and years of asymptomatic hyperuricemia to become a gout patient with symptoms. And this is well illustrated in this slide, showing you that the risk of developing the disease is, of course, higher in those patients who are high level of urate and during a very long period of hyperuricemia. And this is a good illustration of the role of genetic, because with a genetic, patients very early in life have a raise in their urate levels. So for the disease, we have a very nice continuum between asymptomatic hyperuricemia, and we have learned from Leo's talk that urate level, high urate level, is not very good for the health. You will see in approximately 10 to 20% of patients with asymptomatic uricemia that you will observe urate deposit. You can see that with ultrasound, and we will have a talk on ultrasound and asymptomatic hyperuricemia. So you can see the deposit as a DC site. I'm going to talk about it later. And in some patients, you will observe flares, meaning the disease, gout is defined by symptoms, flares, due to what we have learned before, high level of IL-1 in the joints of affected patients. And if the disease is not treated, is neglected, the patient will enter in a very difficult period, which is tophaceous gout. And you are going to hear a talk on tophaceous gout by Korn. So how can we perform a diagnosis of gout? It's not very difficult. According to the EULAR, gout is crystals, so you need to identify crystals within the synovial fluid of the patients. But you are going to say it's not very easy. You need facilities, you need skills to identify the crystals. So when you are not capable to have crystals, for example, it's very difficult to puncture MTP1. So if you are not capable to identify crystals in a patient, you can use clinical score, and you can use, for example, the ACR or the EULAR classification criteria. And we have also the Nijmegen score, which is very helpful to perform a diagnosis of gout when patients are flaring. So the EULAR say when you are not capable to, because the patient, for example, is not capable to speak in Roman, is not capable to speak in French, you can use imaging to see the crystals. And we have two different types of imaging which are very useful for the diagnosis of the disease, which are ultrasound, and we are going to have a talk on ultrasound, and the DECT. And the DECT is a dual energy CT scan which is capable to demonstrate the crystals in the feet or the hand of the patients. Very useful because you can see the crystals during the intercritical period. So this is just a very basic illustration of what you can see with ultrasound. So as I said before, the DC sign is something which is very, very important, and there are two other features with ultrasound to perform diagnosis of gouts, which are aggregates, okay, small crystals within the synovium, and tophi. You have here an illustration of what you can see with DECT, and MRI is not very useful for the diagnosis of the disease. So use ultrasound, very, very useful for the diagnosis and to follow the patients. So how to treat? How to treat? According to the EULAR, there are 5 different therapeutic options to treat flares. You can use colchicine, you can use NSAIDs, you can use steroids, and for very difficult to treat patients, you can use IL-1 blockers. The most important is that we have learned from Terkeltaub study is that if you are using colchicine, use please low dose. It is as effective as high dose, but better tolerated. This is a randomized controlled trial in which patients receive either close to 1 milligram, okay, 1.2 in US, followed by 0.6 milligram 1 hour later, or a high dose, 4.8 milligram during a flares. And you can see that the efficacy was very similar between the two groups. The response to the treatment defined by the decrease of pain by 50%. You can see that it has the same efficacy, but by contrast, the tolerance of low dose is absolutely perfect, very similar to the one you have with placebo. So if you want to treat a flare with patients, use in France, it is 1 milligram. I think it's the same in Romania. 1 milligram, 1 hour later, 0.5 milligram, and then you can repeat that the day after and subsequently in the subsequent days. Main issue with colchicine is that it is a drug with a very narrow therapeutic toxicity window. So it means that in some patients, you will create side effects, you will have side effects, abdominal pain, and diarrhea. So take care with the fact that there is strong drug interaction. So don't prescribe colchicine to patients who are receiving cyclosporine, antibiotic, and particularly macrolide, and tildiazem, because it will dramatically increase the level of colchicine within the cells of the patient, leading to severe side effects. You can use NSAIDs. NSAIDs are very effective to treat flares in the patients. This is a randomized controlled trial which compares low-dose colchicine with the same scheme as before with naproxen, and you can see that the efficacy of both drugs is very similar. So colchicine is very used in France, not very used in UK. In UK, they very often use NSAID. Very effective for a short period of time, 3 to 5 days, works very well. In some patients, you will not use NSAID because of kidney dysfunction, coronary heart disease. And for those patients, I think that steroids is very, very useful. Oral steroids, you can use 30 to 35 milligrams per day. And as you can see here, the efficacy is very similar to the one you will have with an NSAID. For those patients with CKD, coronary heart disease, not diabetic, of course, a short course of oral steroid is very, very effective. But you are going to say, in some patients, we can't use NSAIDs, steroids, or colchicine for different reasons. For those patients, there is a magic wand, which is IL-1 blockers. As we have learned, again, by Leo's talk, the disease is really mediated by IL-1. So what's happening when we block IL-1 in patients who are flaring? We have a randomized controlled trial. We canakinumab versus a steroid. Patients were randomized to receive canakinumab or an injection of acetonide triamcinolone. And look what's happened on the pain. And canakinumab at all time points performed better as compared to the steroid, meaning it is very, very effective, but as you know, canakinumab is very, very expensive. So you can use anakinra. Anakinra is as well very effective, but it's not superior, according to the study, to steroids. That being said, it works very well, and we have a very good experience with anakinra to treat flares in the department. 100 milligrams for 2 or 3 days in difficult-to-treat patients can be very, very useful. In the future, we might have new drugs, and particularly new drugs which are capable to block the inflammasome. This is the case with dapenzotril, which have demonstrated the fact that it is associated with a good safety profile. Is it very effective? We don't know. We will see that in an ongoing phase 3, and I think that in the upcoming years we will have data, and we expect a lot with this molecule because it is very well tolerated, and it seems to be very effective. Blocking the inflammasome, you expect to decrease the level of IL-1 and different cytokines in the joint of the patients. Have in mind something which is very important. What we know from the last months is that a patient who is flaring is a patient with that increased risk of having stroke, myocardial infarction, and pulmonary embolism. This is why it's very important to treat properly the patient, not to treat flares, but to avoid flares. And the way to avoid flares is to dissolve all the crystals. So the most important way to treat the patient is not to treat the inflammation. Very easy, use colchicine inside and you know the story. The most important is to decrease the urate level below the target of 5 or 6 milligrams and to dissolve all the crystals. So according to the EULAR, according to the ACR, the first line drug which should be used is allopurinol. You can use xanthine oxidase inhibitor, allopurinol or febuxostat, and we are going to see which one we should use first. Unfortunately, we don't have uricosuric, and for very difficult to treat patients, we can use pegloticase or raspberry-case. If you use allopurinol, please start at a low dose, and then you do a titration, meaning you will increase very slowly the dosage of the molecule. In patients with mild CKD, with a creatinine clearance of less than 60, please initiate the patient with only 50 milligrams per day. And then every month, you will increase the dosage by 50 milligram increment. In those patients with a creatinine clearance of more than 660, start with 100 milligram. And then you increase every month by 1 milligram until you reach the target. And don't use the ND rule, because if you use the ND rule, meaning if you adapt the dosage of allopurinol to the creatinine clearance, you will never reach the target. So try to reach the target by increasing the dosage of allopurinol. Why? It is very important to start at a very low dose to create a tolerance, because allopurinol can be associated with allergy which is present in roughly 5% of the patients, but in very rare patients, it can be very severe. You might have Stevens-Johnson, Lyell, and Dress syndrome, which are associated with a huge rate of mortality. And risk factor for that is dose in kidney patients, but the starting dose is associated with this risk of allergy, meaning start at a very low dose in kidney patients, in CKD patients. There is a strong genetic predisposition to do this very severe allergic skin reaction, which is associated with this haplotype, B5A CNR2023. So in patients with this haplotype, never prescribe, please, allopurinol. And this haplotype is quite frequent in China, in Taiwan, and in South Africa. Starting dose, this is why it is very important to start at a low dose. The last 10 years, we have learned a lot with febuxostat. What we have learned in pivotal trial with this molecule is that when you are comparing 80 milligrams of febuxostat with 300 milligrams of allopurinol, febuxostat performs better on your weight level. But the most important is that if you adopt a strategy of increasing the level of allopurinol, you will have similar results. This has been demonstrated in this landmark study published by a colleague from the US, in which patients were randomized to febuxostat or allopurinol, but this patient had to have increasing dosage of both drugs to reach a target of 6 milligrams. And if you do that, you have the same efficacy of allopurinol and febuxostat, meaning that you should not stop the dosage of allopurinol to 300 milligrams. Increase the dosage very cautiously, and you will have the same efficacy of febuxostat 80 or 120 milligrams. What about the tolerance? It was very similar for both drugs. So, how can we follow the patients? As we said before, the most important is to dissolve all the crystals. So a good way to see that is to repeat ultrasound. And if you repeat ultrasound of the MTP1 of the knees, you will observe really the disappearance of the DC sign. You will observe the disappearance of tophi and aggregate. And I think it's very useful to show that to the patient because you will increase adherence to the treatment. And when we have dissolved all the crystals, you will say to the patient, you are definitively cured, but continue the treatment, of course, because if you stop the treatment, what we have learned with Leo is that you will observe a dramatic increase in the level of urate, and perhaps that urate is not very good for the tissues. You all know that we should prescribe prophylactic colchicine, because when we start the treatment, we expose the patient to a transient risk of flares for different mechanisms. But when you do a titration, when you go very slowly, okay, do you think that we might avoid, do you think that we need still to prescribe colchicine? The answer is yes. Look at this paper, which was very recently published. This is a non-inferiority trial in which Lisa Stemp had the hypothesis that by doing a titration, no colchicine is needed. It was a non-inferiority trial versus placebo, but you can see that the non-inferiority was not reached, meaning that the placebo was not non-inferior to low-dose colchicine, meaning that I would like to encourage you to continue to use a prophylactic treatment with 0.5 milligram of colchicine when you initiate the patient with allopurinol or febuxostat. This is the first reason, flares. You decrease the risk of flares. Second reason is that colchicine is very good for the heart. We know that from different trials, and particularly from the Lodoco. Lodoco is a trial in which patients were randomized to low-dose colchicine or a placebo. Okay, patients had chronic coronary disease. And the primary endpoint in this study was MACE, major adverse cardiovascular event. And look what happened. In the patient who received colchicine, low-dose colchicine, there was a decrease in the incidence of MACE by 30%, meaning that when you are prescribing prophylactic colchicine, you likely expose the patient to less risk of having cardiovascular events. And what we have seen from the JAMA paper is that each flare is associated with an increased risk of having myocardial infarction or stroke. So we do think that prophylactic treatment with colchicine will decrease the risk of flares and might protect the heart and the brain of the patients. We said that the target to reach when you initiate the patient with ULT is 6 or 5 milligrams per deciliter. We say 5 in patients with tophaceous disease. Should we go lower? Should we go close to 2 or 3 milligrams per deciliter? Likely not. If you look at this trial, conducted again by a colleague from New Zealand, this is a trial in which patients were randomized to a target of 5 milligrams, or a target of 2 milligrams, close to 2 milligrams. And there was absolutely no benefit on structure, on joint structure, X-rays, DECT, and so on and so on. So don't go too low. You should not expect of lowering too much of urate level to have a benefit on an arthropathy, tophaceous arthropathy. You may have learned that from the CARE trials that there was some concern, some issue with the tolerance of febuxostat for the heart. Why? Because in pivotal trial with febuxostat, there was numerically more cardiovascular event as compared to the placebo. So the FDA asked to do a safety trial of febuxostat versus allopurinol. So the same study was conducted as well in Europe. It was a non-inferiority trial in the US, with the primary endpoint being MACE, of course. And what was observed was that the non-inferiority was reached. But by contrast, there were more deaths from any cause and more cardiovascular deaths in the group of patients who received the febuxostat. So it was a mess because the signal was febuxostat can increase the risk of cardiovascular event. It was really a mess, but I'm not going to enter into much detail. There were many biases in this trial. And fortunately, the same study was conducted in Europe. It was a fast trial, very well done. And one of the main issues with the CARE trial is that the deaths and cardiovascular events were observed when the patient stopped to take the treatment. What happened in the FAST? In the FAST, it is the same design, non-inferiority trial, primary endpoint, major cardiovascular event. And hopefully in the FAST, all the data are very reassuring, meaning that there is no signal in favor of cardiovascular event with febuxostat. So the tolerance seems to be very similar. So I'm not going to say that there is absolutely nothing with febuxostat, but there is no strong signal which would say febuxostat is associated with an increased risk of major cardiovascular event. One of the most important with your patients, as I said before, treat after the first flare, or discuss with the patient to initiate a treatment after the first flares, because we have seen that flares are clearly associated with an increased risk of myocardial infarction, stroke, and pulmonary embolism. And when you decrease the urate level, it might be good for the tissues, as was said by Leo. So to do that, please educate your patient. Education, 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 which is very, very important to have long-standing treatment with ULT, because following 1 or 2 years, the patient will stop flaring. And then they will say, okay, I'm well, I stopped the treatment. What's happened? Urate level will grow up very, very quickly, and you would expose the patient again to have flares because the crystals will appear again within the joint of the patient. So educate the patient. Try perhaps to do repeated ultrasound to see the disappearance of the crystals. And once you have done that, you can say to the patient, okay, you are cured, but please continue the treatment. Or if you stop the treatment, do ultrasound to see or not the reappearance of the DC sign. So to conclude, most important, it's not treating flares. Flares are very painful, but it's not very important. Discuss with the patient to initiate ULT, first-line allopurinol, after the first flares. Treat-to-target strategy is of outstanding importance to definitively cure your patients. Target 6 milligram or 5 milligram. Don't go too low. You should not expect any benefit of going very, very low with your patient. Educate your patient, do ultrasound. Advise, of course, of diet, weight loss, but as we have seen, the benefit of that is very, very low. So the most important is to educate the patient and to follow the patient. Many thanks for your attention.